Hord. Hello, I want to welcome everybody to this webinar on treatment options for OCD, fact versus fiction. This is OCD Midwest's third webinar in our series, so I encourage everybody to check out the other webinars on our YouTube channel. My name is Joanna Hardis. I am a social worker in Cleveland, Ohio, and I am joined today by Dr. Patrick McGrath, Chief Clinical Officer of NOCD, Mike Sizemore. He's a board member at OCD Midwest and a patient advocate, and Brian and Mallory, who are also patient advocates. Before I begin, I want to remind everybody that this webinar is for information and educational purposes only. The material presented today is like is not meant to replace anything but from your current treatment team, if you have one. If you are looking for treatment options, please visit the IOCDF to visit treatment providers near you. Their website is www.iocdf.org. And if you are feeling unsafe, please dial 911 or the Suicide and Crisis line at 988 or head to your nearest emergency room. Okay, let's get started. I know I've heard the sobering statistic, and I don't know if you guys have, that it takes the average person with OCD up to 17 years to find effective treatment. Have you guys heard that?
Yes.
Yeah, it's absolutely appalling to me. So I think we could probably do a whole webinar on the reasons for that, which is beyond the scope of today. But I think it's important to just start things off by laying out what are the current evidence-based treatment models for OCD. So I'm going to turn that over to you, Patrick. If you could let us know what the current models that are being recommended for OCD are.
Sure. They come out of cognitive behavioral therapy, and really the behavioral portion of cognitive behavioral therapy, where we're looking at the most commonly used model of exposure and response prevention therapy, which is two parts. We want to purposely expose people to things that are uncomfortable, but they're being exposed to them already all the day long with their obsessions. So it's not like we have to make a massive effort to find something that's uncomfortable for people with OCD, because they are constantly experiencing those obsessions, those thoughts, those images, those urges that they find to be intrusive or inappropriate and cause them a lot of anxiety or distress or shame or guilt or discomfort or disgust or something of that nature. And then we do response prevention, which is getting people to eliminate safety behaviors. And there's really 5 safety behaviors we focus on: avoidance, reassurance seeking, distraction, substance use, and the big one in OCD would be the compulsion. How do you stop somebody from doing a behavior or mental act that, so that physical thing that you do or the mental thing that you do that tries to neutralize that obsession. And when you do that and you get the relief from the obsession, it lasts for a little bit of time. And then OCD, being the jerk of a disorder, of course, that it is, says, hey, nice job. Now remember, don't think about that obsession again. And boom, that whole cycle starts all over again. And you find yourself stuck in this. So we're trying to get people off the hamster wheel of hell. We're trying to stop people from going around and around trying to figure this out. It's the dog chasing its tail kind of thing, and getting people to recognize, oh, I can have an obsession and not have to do something about it. Awesome. Great. So I can't stop an intrusive thought or image or urge from happening in someone's brain. I don't know how to do that. And I contend all of us probably, while driving over a bridge at some point in time, thought, what if I just turn the wheel really hard right now and shot the car off the bridge into the river below? And when I say that to big crowds, they're like, wait a minute, how did he know that? Well, because we all think those types of things. That's just a normal, natural kind of thing. And so we just want people to be able to experience these things in their head and recognize that just because they do doesn't mean they have to do anything about them. They can live their life with them being there, and they can move on and pay no attention to them whatsoever.
Okay. So I heard you say exposure and response prevention.
Mm-hmm.
What about ACT? Because I hear a lot of people talking about ACT. Is that a evidence-based treatment model?
I contend if you're doing great ACT, you're also doing great ERP. So I remember seeing a lecture from my very good friend Mike Tuig, who was talking about here's what ACT is and what we do. And I remember listening to it and thinking, oh, I do all of that stuff too. I might have different metaphors or language for what he's describing, but so I think that our ACT brothers and sisters are doing wonderful ERP, and our wonderfully performing ERP therapists are doing what happens in ACT as well too. And I think they can very much support each other. I love the concept of living a values-based life. And what value are you working toward now? Are you doing this to help OCD, or are you doing this because you want to do this? This is in favor of your life and your values. And when we get people to work toward their own values, we kind of see that you're not working toward the values of OCD. You don't really want to be doing those compulsions and serving OCD. You want to serve what you value in life, which is moving away from compulsions and living the life you want to live and not the life that OCD wants you to live.
That's great. Thank you. I think that's really helpful. And something I hear a lot from fellow clinicians with whom I've worked is talking about evidence-based treatment. And I think it's really important, and not all consumers know this, but why is it important that
Sure.
that people looking for treatment look for
Yeah.
evidence-based treatment?
Well,
There an easy answer for that?
yeah, there is. Bad therapy has killed people in the past,
I love that.
actually. So if you think about, there was something called rebirthing therapy, where someone had an idea of, oh, if people don't have a good attachment with their children, we can perform a rebirthing ceremony, and we could have them be reborn again to their parents to redevelop their attachment. And there was a time that they rolled this woman up in a carpet, and it was supposed to be the vaginal birth canal, and she was supposed to push her way through it and end up in her mother's lap. And she was in this carpet rolled up in it, and she was yelling that she was really hot and she was having trouble breathing, and she said she threw up. And they kept saying, you're just resisting, and they kept pushing her to keep doing it and doing it. And then they didn't hear anything from her for a while, and they unrolled it, and she had suffocated and died. Now, this was not a evidence-based treatment. This was something some people thought sounded like a pretty good idea. There were no peer-reviewed articles on it. What does that mean? That you write an article based on the data that you've collected, and you send it out to other people who also review that article and the data to see, would they come to the same conclusions that you did based on that? And if they did, it has some merit. Then you publish it, and then you get other people doing studies, and you see if they can replicate those studies. And if they can replicate it, now it seems like, okay, this does seem to have some legitimacy to it. And the more that you can replicate it, and the more that the data comes to support it, it over time becomes an evidence-based therapy. We have actual evidence to support these claims that this is actually a helpful thing. So it's not just something we're making up in our head and saying is going to be helpful. And that's from the behavioral health aspect. There's also evidence-based work on medications and as well too. And in fact, if you look at the American Psychiatric Association guidelines for ERP, they're going to say two things: ERP or ERP plus medication would be the route to go for people as well too. Notice they don't recommend medication alone. That is not an evidence-based treatment for OCD, just so you know.
Right. Thank you. And, before we hopped on, I did a search on Psychology Today, and I put in OCD Treatment Cleveland, and there were more than 240 providers that checked off that they knew how to treat OCD. Which I don't know. I'm really curious, Mike and Mallory and Brian, your experience. But I know in Cleveland that there are not more than 240 providers that know how to treat OCD. But I think if you're looking for OCD treatment and you go to something like Psychology Today,
Yeah.
which is a huge clearinghouse for therapists, for
Yeah.
clients looking for therapy, it's really easy to find someone that may not be a specialist.
Nothing annoys me more than when you go to a therapist profile and it asks, what do you specialize in? And they say children, adolescents, adults, older adults, retired people, people with disabilities, people who have anxiety,
Preschoolers.
depression, who have multiple personality or dissociative identity disorder, people who have bipolar, people. You cannot specialize in all of those things. It's absolutely impossible, and it's disingenuous to list all of those things as being stuff that you specialize in. So if you went to a profile that I created for myself, it would say I specialize in anxiety disorders, OCD, and exposure and response prevention based therapies. Those are the things that it would say. It wouldn't say all of this other stuff because it would just not be true, and it would be ridiculous, and people get fooled into it. So it is important, if you meet with a therapist, that you ask them questions. It is okay to interview a therapist and say, tell me about the evidence-based treatments that you utilize for obsessive compulsive disorder. And if they say things like, well, we're going to do diaphragmatic breathing and muscle relaxation, and you're going to come in and you're going to talk, and I'm going to tell you not to worry about it, and every time you have a bad thought, I'm going to tell you to have a good thought instead, run away as fast as you possibly can from that therapist, because they have no clue about what they're doing in terms of obsessive compulsive disorder at all.
Run. And if run. So I'm curious, Brian and Mallory, and I don't know, Mike, if you guys want to hop in with your experience about if you want to speak to your experience, if you had to interview therapists, if you lucked into finding someone that knew about ERP, if you want, I'm going to open it up however you want to launch into it.
Mallory, would you like to go first? I'm good either way.
Yeah, sure. I can share some of my experience. So we talk about people having 17 years until they receive proper diagnosis. I feel really blessed that it only took me like 2 or 3 spent in talk therapy and realizing that the exact treatment stuff that I was working towards was actually making me more sick and more invested in my fears than invested in the life that I wanted to live outside of OCD. And so I had no idea what ERP was before I had a therapist that referred me to an OCD specialist, and such a gift to have someone who knows your disorder and knows exactly it's going to be uncomfortable, but it's going to be worth it to get parts of your life back from OCD.
So it sounds like you found OCD because you had a therapist that referred you.
Yeah.
Okay, great.
Super important.
Sure.
Unfortunately, that was not my experience. I am much more aligned with the statistic. It took me about 15 years to be properly diagnosed and to find someone that could actually treat the underlying issues. When I was about 15 years old, I started experiencing the symptoms of OCD, and it took a while even to admit to go to my primary care doctor and discuss this, and it was just labeled as anxiety, and I was given drugs right away. So, which ultimately just proved to be a Band-Aid on a deeper rooted issue. The drugs work for a little while. They do okay. They lower the anxiety, and they make things a little better for a while. But in my experience, a lot of times the drugs lose their effect over time. Your body adjusts, gets used to it. They stop having sort of the same potency. And so I'd go back to my primary care doctor a few years later, and I'd complain again, and I'd say I was still having issues, high anxiety, intrusive thoughts primarily, which was my version of OCD, centers around intrusive thoughts and trying to seek reassurance or avoid triggers that would cause those intrusive thoughts. And so they thought, okay, we'll just compound it and add another drug. That was the solution. So, and that was so bad, the companion drug they gave me to the original drugs were typical SSRIs like Paxil. And then they tried to add a different drug that was used in maybe more aggressive, like bipolar and other disorders, that made me feel like a zombie, and it did too much damage. Like it shut me down too far. So I stopped. I only took it once or twice and was like, that's too much. I can't do that. So went back a third time seeking help, and they referred me to, and this is no disrespect to the individual, but it was a counselor who had no experience with OCD. And we just sort of talked in circles. I didn't really get anywhere. Was never able to refer me or diagnose me properly. So went back again. Eventually, my primary care doctor retired. I went to a new one, and they referred me for the first time to a therapist who did specialize in OCD and obsession compulsive disorder, and that changed everything. But by the time I made it to him, I was 30 years old. So, and there was some good points in there where the drugs helped, or I was able to good spots where the OCD was lower. But by the time I made it to him, it was because things were getting pretty, there was a lot of anxiety, a lot of avoidance, a lot of high stress. So, but I finally made it to him. And, one of the core components, you mentioned it earlier, was ERP, response prevention therapy. That's a big game changer for me when I really started to see improvement in the root cause and core of my OCD.
Yeah. I think too, you're seeing you can have general counselors and you can also have general practitioners on the medical side who are not trained in these medications to the levels that you need for OCD, because OCD prescribed levels of many of the SSRIs are much higher than the depression prescription, and people are familiar with the depression dosages and then just try to apply that to everything, and it doesn't really touch the surface of what needs to happen. So that's why many people will also kind of linger in this land of, I feel like I'm being treated, but it's not treating me, and people feel stuck.
So I'm curious, once you guys got into ERP, because I think this is where a lot of new clients or people who are considering ERP get really nervous, because they may have seen on TV something about exposure therapy or read something, and they're so scared. And they have all sorts of beliefs about what it's going to be like. And one of the things that I hear a lot about people coming into therapy is the fear that, one of the top fears, like if we were going to play Family Feud, one of the top fears is that they're going to have to stop all their compulsions all at once. It'd be kind of fun to play Family Feud about, like, what the top myths about about like ERP would be. But, one of the things that I hear a lot is, am I going to have to stop all of my compulsions all at once?
No, that's a great recipe for scaring people away from therapy, actually. And I think that's just, only once have I done that with someone, and it was because they specifically said, I'm a flutter. My personality is not to build up to things. I just jump in and do it. And I've decided I want to stop OCD, so I want to go to the top. In 23 years, I've done it one time because it was a very specific request from one person. But otherwise, I do hierarchies with people, and we build up this ladder, and it's a journey. I have a little funny saying. I say, my favorite Irish phrase is, only an Irishman can tell you to go to hell and make you look forward to the journey. And that's how I look at ERP. I'm going to ask you to do really, really difficult things, and I want to try to make you look forward to doing them. And so I'm not going to do that by just taking the most scary thing and throwing at you. I'm going to take the tiny thing, and we're going to put a toe in the water and see how it feels, and we're going to build from there.
Mm-hmm. And I see you, Brian, and Mallory nodding your head. So that must be that was, you have some nods of recognition.
Yeah, I use the analogy when asked like what it was like doing ERP, and if anybody had any questions about it. For me, it was very similar to weightlifting or exercise. If your goal is to bench press, or squat 300 pounds, you don't walk into the gym and put 300 pounds on the bar and try and squat it. If you've had no prior experience, no training in that, you build up to it. You start with 30, you see how that works. Once you conquer that, then you add 40. And it's a process, like Patrick mentioned, it's a journey, to get there. You have the ultimate goal in mind. You want to be able to be strong enough to handle these triggers or these fear-based situations that cause the OCD to go nuts, but you have to work your way up there for the most people. I mean, I'm sure there's some people that I've heard of flooding and stuff. There's some people that do just want to jump in but for the majority of people, you work up to it like that.
Mm-hmm.
Mm-hmm.
Yeah, for me, it was, I needed a little bit of a buy-in. I wasn't 100% convinced, and to have someone tell you that you're gonna have to stop every behavior that's been keeping you safe, I'm sure it just sounds awful. So when I was given the choice of, hey, like, let's start something small, get some confidence, start building up, that changed the game for me. And also having a emphasis on ACT for me has been very helpful, because if I'm not viewing my values or what I want back from my life, I really could care less what time I spend doing compulsions, but if they're keeping me away from the people I love and the things I love to do, then like that was like the true motivator for me. So I love encouraging people to kind of find like, what are you mad about that OCD took away from you? And let's start there, because that's what matters.
Excellent.
Just to speak on your question, Joanna, also about what do you think keeps people out of wanting to engage in exposure and response prevention and things like that, is I can say that was definitely me, for because I knew about the concepts of ERP for probably about 12 years beforehand that I actually did it, and that was exactly why I didn't want to get engaged with it. Was because I just couldn't conceive of even doing it. It was like, my mind wouldn't even go there, because I thought, how could that even be done? And until I had got to such a severe place where I was like, I have really nothing else to lose. I have to do this. And the good news is that it was way easier. In some respects, it was way easier than I thought it would be.
I describe OCD like Stockholm syndrome, right? It is your captor that you are now afraid to not be captive of, right? Because even though you hate OCD at the beginning, you hate having to do the things to get rid of OCD a little bit more than you hate the OCD. So, and so sometimes I talk about people being 51-49, like 51% of me wants to stay the same and 49% of me wants to change. And I want to switch you to a 49-51. Only 49% of me wants to stay the same and 51% of me wants to change. And if I could just make that 2% switch there, then bam, all right, good. Now we're in it. Now we're doing the ERP.
I like that. I want to go back, Mike, to something that you said, because I think I'm really curious about it, that it was way easier than you thought it would be, because I think that I certainly have that experience working with people, but can you speak a little bit more to that?
Yeah, definitely. I mean, I guess the best way I can say that would be the picture of the overwhelming picture that OCD portrays over and over again. Part of its power is the idea that that it's going to be so massively overwhelming that you couldn't even begin to handle it. You just but then once you commit yourself to actually doing it and feeling all those feelings and really engaging in the response prevention and everything like that, and you finally get to that place, and it's like, I remember the first time it happened. One of the first times it happened to me, I thought to myself, that was it. I mean, like that was what I was waiting on for like 20 years.
I know I've worked with so many clients who have the same experience. I don't know if Brian or Mallory, you've had that experience too when you started doing ERP, that what you expected the exposures to be like, it was nothing like, it was so much easier than what you expected.
I think for me, it wasn't that they were easier, but I didn't expect such a sense of freedom or a sense of like accomplishment afterwards. No one told me how good that was going to feel when you face your fears. And yeah. What about you, Brian?
Yeah, I concur completely. One thing I kept thinking about, I'm glad you brought that up, Mallory, when Mike was talking too, is there's another side of ERP that hasn't been mentioned yet. Was, at least for me, what I experienced and what you said you did, was it was intense for me at times and scary, especially at first, based on what my fears were and putting me in that position. But what I always felt afterwards, like after facing down the fear, doing the exposure and stuff, was a sense of relief and confidence building that I hadn't had before, ever, with OCD. So it was like a little bit each time, a little carrot at the end of the stick that said, you can do this. This is something you haven't been doing. And now you just proved you can. And each time you're proving OCD a little bit each time, a little bit more of a liar. All these fears that it's showing you are not true. And you can't do these things that it's telling you you can't. And that feeling of relief and a little bit of confidence building each time can almost be, it not only reinforces it, but can be something you don't want to get too far down that road, but it's something to look forward to out of that.
I think I love that. You know, something that I think might be helpful for people that are considering ERP or new to ERP or even doing it is realistically how long people are working on exposures on a daily basis. Because I think it's unclear, you know, I think this is something that is kind of unclear for people and it can be confusing. Because I think probably every therapist has a different recommendation for how long people should be doing exposure homework. So I don't know if any of you could speak to that how long you might have worked on or your exposure homework, and then maybe outside of the exposure homework, how long you might be working on just unplanned exposures and maybe shifting how you're responding to things. And Patrick, you can certainly hop in too.
Mm-hmm. I'll let them go first.
I can say one thing that came up for me was, as far as exposure goes, are you meaning like currently to this day, do I still do unplanned and things like that? Is that, if I understand the question correct?
I would love to know both.
Okay. So yeah, at first it was very structured. Like I would do these specific targeted things that, you know, would put me in situations that would trigger intrusive thoughts, would trigger the OCD, and I'd have to prevent the responses, the bad habits, the things that I would do to try to, you know, the safety behaviors, I think Patrick called them. And that was very structured at first. And then it just became, you know, as much as I wanted to do it. And to what I said previously about that feeling you get of accomplishment and sort of empowerment that comes with that, that would also motivate me to push a little bit. And that's, you don't, you know, depending on the patient, the individual, but it would, when I would be in a high stressful situation, I would think if I could just go a little further, this will accomplish a little more. It will give that, it will create more confidence in me. So if I can endure a little longer, stay here a little more, resist the reassurance activities a little bit longer, it's going to relate in more confidence, a little more that, hey, you did it a little longer. And then to your point, unplanned things, the same kind of thing, you know, it all worked over time. There was a foundational shift in my personality, and this still occurs for me today, where 8 years into treatment, my response, my habitual response now to fear and things like that is to, most of the time, it's not perfect, but most of the time is to run toward it, not away from it. Because I spent my life running, you know, for 15 years, and now it's shifted, even foundationally, even other things I'm afraid of. I will attack the way that ERP taught me to, the same thing, go toward it, go embrace it, because that is the surest way that I've experienced in my life for the fear to lose its power. So go face it head on. Do not run from it. It could be personal. It could be, you know, uncomfortability with heights, things like that. Go do it. Go challenge it. And that's kind of, in my therapy, we talk about the words we use is challenging it. So meet it at the apex and challenge it. Don't run from it. That's shifted in my life to where when I'm afraid of things, there's still times I use it where I will face the fear. That's kind of been the mentality and the change, the foundational change that's occurred to me over the 8 years of therapy and doing ERP.
That's great. And so I totally hear you. And what I hear is it's hard to put a like a minute or an hour number on it, because it's such, it sounds like such I love your words, foundational shift. So it may be hard to answer that, but I think it's so hard for new people because 30 minutes is clearly probably not enough for someone to get that shift.
Right. If they're just starting out, no. But I can tell you that when I started, it started with a picture. My therapist recommended take a picture of something that triggers the thought and stare at it. And I want you to stare at it until you get bored. So you just keep going until there will be intrusive thoughts and that, but hang in there until you get bored, and you will get bored. And I did get bored, and that surprised me because I'd never faced it that long, just stared into the abyss, if you will, for that long. But I did. And then it worked its way up into, okay, now we're going to graduate from the pictures and things to real life. We're going to put you in a situation where, you know, structured, but the same trigger in real life. And it worked its way up from there. So in the beginning, 30 minutes may be enough if you're starting small like that with a picture to feel something, but you're not going to get a foundational shift just doing it a couple times, right? It's going to take hard work, like anything worthwhile in life, right? It's going to take work and commitment to see and the end core foundational results that you want. But I can tell you it can be done. It does happen. It just takes those things. But that, I would say, most things worthwhile in life take those same things. And believe me, it's worth it. Otherwise, you can live in the OCD prison. That's your other option for, you know, another 15 years.
Right. What about the rest of you guys? I love your answer. Thank you.
I can share. So I don't do well with time limits. That's just my personality. And so when my therapist was like, hey, like, we recommend people do this for so many minutes a day, I was like, ooh, I don't think that's gonna work. And so the big thing for me was setting goals. So I have so many goals I want to hit one day. I want to redo all these exposures, and maybe, like, let's say I can do an exposure for 5 minutes, and the next day I can do it for 5 minutes and 30 seconds and try to make it a little bit more of like reaching goals and making it more of a game. Was just helpful for me, because when you think about like someone telling you to do exposure homework for an hour and a half, you're like, okay. And some of us, I mean, have panic attacks, and that's one thing you never know if that's what exposure is going to lead to. And so you're like, oh, well, that's going to be a 90-minute panic, and that sounds awful. But when it's more manageable and in smaller bites, I feel like it's a lot easier.
Great point. Thank you. Mike, Patrick?
I
Go
just,
ahead,
one thing that I'm sorry, completely lost reference of your question. I apologize, Joanna.
That's okay. What's a reasonable amount of time that you may have worked on this stuff initially or currently to maintain progress?
Okay, thank you. Initially, I was doing, I was doing planned exposures. You know, I, for me anyway, I knew that I couldn't set myself up almost like for a failure in my own mind to say like, well, I only do these 5 times a day, because I knew that that was kind of the wrong attitude to say like, I shouldn't really put a limit on how many times I do something that that I'm supposed to do in therapy. I should be doing it more frequently. I mean, because saying that I'm sticking to a limit of, only a set amount of times a day kind of interprets to me like, I'm only doing the bare minimum. I'm not doing any more than I have to, kind of thing. So I tried to do it as pretty much as often as I could, and 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 from there it was just kind of like, whenever the OCD was really trying to take hold of me, I would immediately kind of pivot and go do something that I was supposed to do. And then from that point on, kind of how I maintain things is I live that way. I have no desire to go back to where things were before.
I love that. And Patrick?
I always talk about the idea that if you like sports, and I'm not a huge sports person, but if you like them, even professional athletes have coaches, and even they practice. Right? Great musicians practice. Eric Johnson, great guitar player, saw him open for Rush, greatest band ever. And Eric practices guitar 6 hours a day, and he's got a Grammy award for an album that he did, Cliffs of Dover. It was a great album. And here's a guy who's on the tour bus And he's not just sleeping on the tour bus, he's playing the guitar the entire time on the tour bus, driving to the next show. And then he does a 3-hour show. And then the next day he plays for 6 more hours in the morning. And then he does another 3-hour show, right? To become awesome at something, you not only develop the skills, then you maintain the skills, right? So there's two parts to overcoming OCD: developing the ERP skills to get you to the point where you're living the life you want to live and not the life OCD wants you to live, and then maintaining that experience as well.
Nicely said. And I like that from everybody's answer, there's no one right way. That was hard to say, but no one right way to do it. There's lots of different ways to do it and to be successful. So before we close out, anyone have any final words that they'd like to share about ERP or ERP, about treatment, for people that might be looking or watching this or about to go pursue treatment? Anything that anyone would like to share before we close it out?
I would just say treatment's available. There's online platforms. That's what I love about working with OCD. And there's in person now that COVID is up. So you have multiple options of being able to find people who are well trained in utilizing evidence-based practices for ERP and OCD and related disorders as well too. So just know that there is help out there. But interview therapists to make sure they know what they're doing, and don't just take the fact that they clicked a box off that says they know how to treat OCD, meaning they actually know what they're doing.
I'd like to add that a hallmark of OCD too is shame. So what prevented me maybe at first from seeking help is that if I explain what's going on in my head, that this is going to be horrifying to people, even doctors, or I'll be judged and all that. And that can't be further from the truth too. So as Patrick mentioned, now it's better than ever too. There's online resources, there's in-person therapy. There's so many options where you can find somebody, even if the first couple therapists you met, it doesn't work like it didn't with me. There's others out there. Just keep going until you find somebody. But what I can tell you from my experience is they're not going to be surprised. No matter what you think or how scary it is, they've dealt with this before. They've heard about it before. There's research. I mean, I was shown a lot of books that helped me a lot to understand it, that made me realize my case wasn't that obscure or strange or anything, that other people experience this stuff too. And that made me feel a lot less shame and also a lot less fear in sharing what I was feeling inside. So if you're holding back, if you're avoiding it because of that, don't. There's a lot of great, sympathetic, understanding doctors and professionals out there that are ready and willing and understand and know how to help you. So there is no reason right now to avoid it for that purpose, for that reason.
Excellent point.
Yeah, that was great. And on the IOCDF website, there is, I believe, a page that talks about interview questions that
yes,
you can.
Fred Penzel did an article about that. Absolutely.
Yes, that is really fantastic. So please make sure that the person you are interviewing is a specialist in OCD. I cannot stress that enough. Mallory?
I have one quick thing.
Sure.
When I started treatment, no one told me that ERP could be used and would not be an insult to my faith community and my religious practices. I entered the game thinking that I was either going to lose my faith or I was going to be subjected to someone who thought that my faith practices were like all intertwined with my OCD, which was true. They were intertwined, but if you have a real OCD specialist, they're going to understand how to help you live your faith out in the way that you want to live it and to kind of pull apart OCD's hands in your religious practices. So as a person of faith, I was terrified. It's really scary to attack those fears related to your religion or related to morality, anything like that. But if you have a specialist that knows and can help, it's it's life-changing, and just to take that first step, I think you'll start to realize that you kind of get a real picture of who your God or your higher being is outside of OCD's lens of it.
And that therapist doesn't have to share your faith, because they're not there to convert you or you to convert. They are there to untangle that, and that's what they're an expert at. But it's okay if they don't have the same faith as you. There's no influence they're trying to make on your faith. Exactly.
That's a great point too, Mallory. And I'm actually a person of faith myself, and found that OCD, it actually helps strengthen it, the whole process, because OCD wants certainty, right? And learning at the core, some of these things, including ERP, take leaps of faith. And having faith, you don't get certainty with this stuff, but you take leaps of faith and you can see how far you can go. That only works in my experience to help strengthen that. Taking leaps of faith and having faith is a worthwhile endeavor and part of me.
Great points. Thank you all so much. Thank you to Mallory, Brian, Mike, and Patrick for doing this. And I hope it was helpful for everybody, and hope everybody has a good weekend. Thank you. I'm gonna